Good evening, everyone. Welcome to AVPN's first South Asia Impact Capital Festival. I am Dendra Rikmas, Senior Product Associate with the Knowledge and Insights team at AVPN. I will be your MC for this session, and I'm delighted to have you join us today. For those of you who don't know about AVPN, we are a network of funders and resource providers with over 600 members across 32 markets. Our mission is to move more capital towards impact in Asia, by providing social investors like yourselves opportunities to connect with key stakeholders across various sectors and markets, to learn from one another, and to find opportunities for action. We are sharing highlights of a day live on Twitter, so don't forget to share your experience with us by using the hashtags #AVPN South Asia 2021 and #SocialImpact. Throughout this month, the festival will spotlight best practices and solutions that AVPN members are delivering across India, Bangladesh, Nepal, and Sri Lanka. They will address issues ranging from healthcare, livelihoods, climate action, and education, all of which are of particular urgency for the sub-region today. Before moving to the program proper, a few housekeeping announcements. To download any session resources, please click on the download icon in the agenda page, which is next to the session title. To continue chatting with your speakers and fellow delegates in this session, please make full use of the messaging function or the event feed in the platform. Finally, please note that the session will be recorded and you will be able to access the recording for 3 weeks after the festival. This week, the festival focuses on healthcare. During this session, Improving Primary Healthcare in India through Tribal Health Collaboratives, one of the leading organizations that deliver public health solutions in India, will share its learnings around strategizing and implementing large-scale primary healthcare solutions that are based in gaining an in-depth understanding of the health and nutrition status of tribal and marginalized populations in India, and shed light on how a coordinated and collaborative approach can systemically address challenges in the field. And with that, I'd like to introduce you to our moderator, Mr. Ashwin Deshmukh, Vice President Advisory at Piramal Swasthya. Ashwin, please.
Thank you, Dandi, and thank you, AVPN, for having us here. I would request to play the video, please.
Nearly 60% of Indian population lives in rural and tribal areas. A minimum distance of nearly 5 kilometers has to be covered to reach the nearest health facility center. Araku Valley in Visakhapatnam district of Andhra Pradesh is inhabited by different tribes and is surrounded by mountains. Tribal population residing here are generally disconnected with urban people and deal with major challenges like illiteracy, poverty, lack of awareness of hygienic practices, geographical conditions, etc. Piramal Swasthya's Asura Project is an initiative to provide free maternal health care services to the pregnant women in Araku Mandal through community outreach program and specialist services. It covers 181 habitations of Araku Mandal, catering to a population of approximately 43,000 people. Fixed day visits are made to these habitations by Piramal Swasthya's trained outreach workers for screening of prospective mothers. Counseling on healthy practices to be followed is also given to young and adolescent girls. High-risk pregnancy cases are identified, validated and confirmed with the specialist at the telemedicine unit. Dr. Rajya Lakshmi, one of our specialist doctors, shares her experience with beneficiaries.
My whole period of the experience, I served only in secondary and tertiary centers and I never come across these villages. And I am very much astonished to see the conditions of these people after entering into the remote interior hamlet of Araku. Actually, these people are living in a very, very bad circumstances and they are very much deprived of the services of all types and they are underserved rather than subserved.
Asura is a unique and comprehensive model which has depicted a sustained impact for a good period of time. The institutional deliveries have significantly increased with zero maternal mortality in past 2 years in target areas. This model addresses the complex challenges of making healthcare accessible and available to remote tribal populations making a sustainable impact on the tribal communities of Araku Valley.
Thank you, and good evening, everyone. I am Ashwin Deshmukh. I'll be moderating this session today on Tribal Health Collaborative. That's an initiative of Piramal Swasthya. Let me begin with introducing Piramal Swasthya first, and then we'll move to the speakers today. Piramal Swasthya is one of the largest not-for-profit organizations working in India in public primary healthcare delivery. Our focus areas are maternal and child health, non-communicable diseases, and infectious diseases. We've been established in the year 2008, and over the last 12 years, we've gained huge experience in working in the field along with the governments. We've been running the tribal program in Araku, the video that you saw, since last 9 years now, and we've seen significant outcomes there. Overall, Piramal Swasthya has also been working on the system side, helping governments in strengthening their public healthcare delivery mechanisms. We've also been working in the aspirational districts for past 3 years now, and we've gained significant gains in the health outcomes in these aspirational districts as well. Let me introduce you to our two speakers today. We have Mr. Paresh Parasnis, who heads Piramal Foundation, and he supports the 3 initiatives that Piramal Foundation has: Piramal Swasthya, Piramal Foundation for Education and Leadership, and Piramal Sarvajal. Through his strategic inputs, his project management expertise, and his expertise in building various key models of service delivery. Our second speaker here is Dr. Shailendra Hegde. He is a public health expert. He leads the clinical domain and innovations vertical at Piramal Swasthya, and he looks at creating various models, healthcare delivery models, which can be scaled up sustainably across various regions, various geographies of the country. So welcome, gentlemen. We all are happy to be here. And let me begin with asking Paresh questions about Piramal Swasthya's journey in the tribal areas of Araku and how Swasthya has evolved through those learnings over these years. Paresh?
Sure. Thank you, Ashwin. I think, again, thanks to AVPN for having us on this discussion. It's indeed a pleasure to kind of share our thoughts and our learnings from the work that we've done in tribal health. Ashwin, as you mentioned, Piramal Swasthya started work in Araku, I would say almost 10 years ago now. Swasthya was set up more than a decade ago, and I think it's been about 9 to 10 years that we started working in Araku. Araku is a remote part of the Andhra Pradesh state, based in Vizag district. And I think the kind of challenges that we saw in Araku at that point of time, in terms of access to primary healthcare services, of course, affordability was a challenge, and the availability of healthcare services was something that attracted us to Araku. I guess, in a sense, it also was the beginning of what we are going to be talking about later in the course of this discussion on tribal health holistically. I think given the fact that India's tribal health population numbers almost 100 million plus, makes up almost 7% of India's population. So Ashwin, as you said, when we said that Swasthya is focused on maternal and child health, I think it was important for us to pick up a significant constituency from that overall population that we are serving as the country, and really use that as, I wouldn't say an intervention, but a constituency that we would go out and develop models for. And that was really the beginning of Araku. I think the second thought really came from how Piramal Foundation, Piramal Swasthya have approached their work over a period of time. We've always believed that the capital that we put in is essentially risk capital. It's a classical case of what one would call venture philanthropy, to say that problems that have evolved over the last 70 plus years and are still as complex and as deep require an approach or require a solution which really breaks out of the current mold and takes a fresh look, a fresh perspective on some of these problems. I think Araku was a classical laboratory for us to try out a new way of really reaching out to that community. And the third, I would say, is really saying, how do we, while we are innovating and coming up with a concept that we believe can deliver discontinuous results, also partner with the government? As you know, we have never kind of tried to do something which is outside of the government, which is parallel to a government system. We have always partnered with the government. So I think the combination of an innovation-led approach, a partnership with the government, and picking up a significant constituency that can help us impact India's SDG targets on maternal and child health was really the beginning of Araku. I think we have seen that Araku has challenges on access, as the video also kind of talked about. It has challenges around deep social and cultural beliefs that hold back a community from health-seeking behavior that would be very common in an urban or even a rural part of the country. The third is, I think, coming to a more solution approach, really saying that the remoteness and the lack of trained medical personnel, health personnel, and that percentage is almost 75 to 80% in the tribal areas of the country. How does one deploy technology in a manner that distance can be eliminated? So Dr. Rajalakshmi that we spoke about, that we saw in the video, essentially is a specialist who's available in a large city of Hyderabad, but is able to converse with pregnant mothers who are sitting in Araku. I think the deployment of technology and telemedicine to bridge this gap of health professionals was, I think, the third element that we really had to look at. And the fourth, I would say, is really going back to our government partnership, the referral that we started building with the government healthcare system. Araku has a hospital, has a community healthcare facility, and the referral facility that we were able to build up, I think are possibly approaches that I would just touch upon as we delve deeper into this. And I think over the last 8 years, we started with 180 habitations. We today work in more than 800 habitations, almost 200,000 population size. And I think we've been very excited by the fact that almost 70% of these expecting mothers today receive checkups at all 4 ANCs. 80% of high-risk pregnancies are getting referred to a specialist. The fact that almost 90% of mothers are going in for institutional deliveries, or a similar number actually are breastfeeding their babies in the first hour after childbirth. I think a lot of what one could call key milestones is what the Araku program has really taught us. I think the engagement with the community has brought in a different flavor to how we can really construct a solution that not just keeps the community at the center of how we create that solution, but also builds a very strong ownership for that solution. I think that's really been the learning. I think the whole community dimension of the work that Swasthya has done, I think to my mind has been one of the biggest learnings of our work in Araku. And I think that's almost like Ashwin saying that it's a bottom-up approach that we built in Araku, right? Starting with the community and saying, so what is it that we can do? But I think it would be interesting now to maybe flip the equation, so to say, and really, maybe I'll turn this back to you to say that while we learn from the community, I think given the aspirational districts program that you have led over the last 3 years and that you referred to, how has this kind of really worked from the government side, as we call it, the supply side? How have we really worked with governments in ensuring that the demand that is being built up through the community is also being efficiently met through the government healthcare system? Maybe I think you could touch upon that to bring out the holistic picture of what is possible.
Sure, Parish. I think 3 years ago, when we really stepped into the aspirational districts program, when it was time to really design a program which is going to address a lot of challenges that you mentioned in terms of accessibility, in terms of HR, quality HR, services, quality service delivery, uh, we've seen that the government had an aspiration to bridge the gap in one of the most remotest districts, or so to say, the backward districts, where the human development index was, pretty low. So when we started designing this program, we looked at both the aspirations. One is in terms of what the community needs are, and that's where the strength of Swasthya lied. So we really went to the community, tried to understand what are their perceptions around public health delivery mechanisms, what are the challenges they face while accessing these issues, the healthcare delivery. And we also then sat with the government to understand where they have their own deficiencies, where they feel, they struggle with delivering these services. So we looked at various elements of the supply side, whether it is people in the healthcare, whether it is the processes, whether it is the policies, whether it is the infrastructure, the hard infrastructure in terms of facilities, or the softer elements of the infrastructure in terms of diagnosis, medicines, etc. So how do you maintain that balance is something that we were juggling with when we started this. And then over the period of time, what we really looked at is, the building the capability of the system, of the government health system, right up to the bottom, right? We started off with the frontline health workers. We looked at the block level resources that, or the subdivisional resources that the government has, the district level capabilities, even the state level and the national level capabilities in terms of how the delivery happens in the field. Where we saw a major gap was in terms of supply chain. Government was able to procure, but was not able to deliver on time on the field. So we looked at those process elements. Do they need tweaking? Do they need redesigning? And each state had its own, challenges and ways of approaching this issue. We also looked at people. We also looked at putting in specialists. So government started, recruiting people by reverse bidding. They could quote their own rates. So there were innovative ways of how we looked at solving these challenges. And the third bit that we looked at is also, the governance part of it. How does governance happen right at the implementation level? How does a district collector or a chief medical officer of a district review his program rather than just looking at, what is happening on the output numbers? The focus more was on solutioning, identifying root causes of where the gaps in service delivery were. Today, we would, see that the overall improvement in these aspirational districts has been significant. Like in the current NFHS 5 data also showcases that the pace at which the aspirational districts have improved in certain indicators, such as institutional delivery, in terms of antenatal care, is faster than the non-aspirational districts. This showcases that, there is a will from the government to reach out to these marginalized communities. There is, a demand from the community as well. It's just that how does, the public philanthropic partnerships together to make this happen. I think that's a key learning for Swasthya as well.
So maybe Ashwin, can I request you to also touch upon two of the core principles of this program? I mean, convergence and collaboration, because this was in partnership, strong partnership with the government, right up to the district level, at the state level, and at the central level. How the principles of collaboration and convergence really played out, and what does it really mean?
Right. So I would start with collaboration. That's where we came into the picture, Piramal Swasthya, Piramal Foundation, how it started engaging with Niti Aayog at the central level, which was really the nodal for the aspirational districts. We started coordinating with the Ministry of Health and Family Welfare at the central level, Ministry of Women and Child Development. We also started working with the state and district level and the block level, which is really the last unit of change that we look at. And we had people and resources deployed at different levels to showcase that we are not just there to provide them solutions, but to handhold them. So that trust of multiple partners like-minded partners. We have Piramal Swasthya working there. We have Piramal Sarvajal, Piramal Foundation for Education Leadership. We have UNICEF. We have multiple other partners working in the aspirational districts. How do we all come together to the common agenda and collaborate with the government? I think that's the key here on the collaboration side. Now on the convergence side, it's what we also observed was, each ministry, whether it is women and child development, whether it is health and family welfare, whether it is drinking water and sanitation, they have their own programs and initiatives working in the field, addressing the same community, but it was not happening in a convergent way. When you're talking about the same constituency, how do I go with a convergent approach? So we picked up areas where there was maximum convergence, areas like village health, sanitation, and nutrition day, where all departments, whether it is drinking water and sanitation, development, coming together and delivering services together on a single platform. That also built a lot of confidence in the community, saying, yes, the intention is to deliver the services. That also led to, the empowerment of the district collectors, because district collector is the administrative head for all the activities, all the departments that are there in a district. And he was also empowered in this program. He could seek support right from the state department or from the central ministry for the various resources he needed. So there was convergence, not just in terms of various departments, but convergence between the district and the state administration and the central government as well. I think that has played a key role there overall. And also the third element I would touch upon is the competition. There was a competition between these to deliver better, and they were incentivized post they performing on certain indicators. I think these three things have really worked well overall for the success of the program.
Right.
I think it is time now to really, bring both these learnings together, and how Swasthya is now looking at its overall vision to transform the health ecosystem through high impact solutions, partner and thought leadership. Here, I would really urge Shailendra to touch upon the Tribal Health Collaborative, which is the key objective of this session. That first, why did Swasthya come up with the Tribal Health Collaborative, and what's the overall vision of the Tribal Health Collaborative?
Yeah. Thank you, Ashwin. Thank you, Paresh. I think both of you have very nicely elucidated the learnings of both what we did in Araku Valley and what we did in aspirational districts. At a juncture where we were trying to understand how better we can work based on the learnings of Araku and aspirational districts, was when we started looking at scaling up of all these learnings into the most needy population of the country. And that is how we started looking at models of how can we scale the learnings. Our initial intention was scale what we have done in Araku, scale exactly the same thing in other places. But we realized very quickly that that is not the actual way of scaling up, because there are obviously challenges which are localized. There are obviously solutions that have been tested out elsewhere. There are best practices that have been tested out by different practitioners and players in the ecosystem, both in the public sector and in the private sector. There are some stalwarts in the tribal healthcare space who have done tremendous work over decades. Our idea was to really try and bring these things together. How do you really learn from not just our own work, but also from others' work? And that's how we started looking at creating what we now call as Tribal Health Collaborative. As Paresh mentioned, about 105 million people in India are actually considered to be tribal, and a large percentage of these people have challenges. When you look at the health indicators of the tribal people vis-a-vis the non-tribal population, we know that the mortality rates, the morbidity rates are all much higher in the tribal population as against non-tribal. And why does this happen? This happens because these people have been systematically marginalized. Their challenges are very unique. They have challenges related to access, affordability, availability. They have challenges that need to be addressed through a collaborative approach. And our belief is that without a collaborative approach and bringing together different partners, different stakeholders, and the community and the government together, we will not be able to address the tribal health challenge that we face. And if you're not able to address the tribal health problems, we will not be able to achieve the sustainable development goals that India has signed up to. So Ashwin, whatever we learned in the aspirational district, Paresh, what we learned in Araku, essentially drives the overall strategy of one part of the collaborative, which is trying to facilitate the implementation of interventions on the ground across different levels within the government. So it's not about the tribal health collaborative wanting to replace the government, but it is actually trying to build capability within the government, within the public health system in such a way that together we can actually bring about changes on the ground. So facilitating implementation of interventions is one core function of the collaborative. Another very important area where we see a lot of gap is related to the knowledge dimension. What do we know about tribal people? We know some issues, but we don't know much more about the tribal people. The Tribal Health Collaborative gives me an opportunity to bring people who have worked a lot in different stakeholders, curating knowledge. And if we are able to bring the same kind of an approach for the tribal people, we will be much richer in understanding the issues, understanding the needs, and understanding what the tribal community themselves also want. And so the second big pillar of the last piece of this puzzle, as I think Paresh and Ashwin both mentioned, is on the technology piece. So the whole way of looking at healthcare at this point in time is how can I make it more accountable? How can I make it more? How can I make it easy to govern? And how do I really share data to be able to do both these things? Also, how can I take the data from these programs and interventions and try and replicate it elsewhere? So it's both internal looking and external looking. And so therefore, if I want to bring in data, a robust data management system, I need a good, strong, robust technology platform as well. So the third piece is basically how do I integrate technology into the overall system of the tribal health population in India? And so the third pillar becomes the technology piece. There are different ways and means in which we can touch upon that, but probably in the interest of time, I'll not get into the technology piece. But these are the three broad functions of the collaborative, of the Tribal Health Collaborative. And these three, we believe, are essential to be able to achieve the vision of the collaborative, which is to end preventable deaths. And while we talk about maternal and child health, we should also be very, very careful now to say that tribal population are also affected by diabetes. They're also affected by hypertension. They're also affected by other non-communicable diseases. And therefore, I think it's time now to look at comprehensive primary healthcare as an approach to address tribal population in India, tribal health in India, and thereby ending preventable deaths, not just related to maternal and child health, but also beyond. And that's what is the approach of the Tribal Health Collaborative.
So, Shailendra, there are a couple of questions that have come up, and one very specific to what you also mentioned about is community involvement. So there is a question saying, how are we involving community in this entire process? Could you give some thoughts?
So the two core principles that the Tribal Health Collaborative has tried to work on is one, engagement with the government, and the second one is engagement with the community. And I'll come to the engagement in the government in a while. But engagement with community is going to be the key if we have to really crack the code of the tribal health in India. So there is no single representative organization or a representative body for all tribal population in India. So we have to look at customizing and localizing the way in which we engage with communities. The one thing that we can look at is what we've tried to do in our aspirational districts, where we've tried to engage very strongly with community leaders, both formal and informal, with religious leaders, with key influencers within the community, within the villages, and thereby trying to create a platform, a network of these people who we can then leverage to really drive home the message and drive home the agenda of providing primary healthcare to the community. This also provides us feedback. This also provides us with the knowledge. What is it that the community needs? What do people require? Do they really require maternal health, child health services? Do they require nutrition? Do they require hypertension treatment? Or do they not require any of this? So I think the way to engage is to identify influencers within community at different levels, trying to build a network of these people, which will then act as a bridge between the community and the health system and the tribal health collaborative. At the same time, working with the government also gives us an advantage, and it gives us the leverage for scale. It gives us authenticity, and it also gives us an ability to engage, get more resources allocated within the system, get the government stronger, capable enough to address the tribal health challenge in India. So I'll stop there, Ashwin.
Thank you, Shailendra. I think the natural next question that has popped up is, how do we engage with the collaborative? How do we partner with the collaborative? So if you can put some thoughts on it.
So the Tribal Health Collaborative has tried to be as flexible as possible with respect to getting more and more people involved in it. So there are different kinds of partners. We've looked at 5 broad categories of partners. One, what we call as core partners. Core partners are organizations that will obviously provide funding, but in addition will have a role to play in governance, will have a role to play in co-creation of the design, strategy, and implementation of the collaborative. Then we have funding partners who may not be having a governance or a co-creation role, but whose funding would be essentially channelized to specific aspects of the collaborative. And the funding could go specific towards nutrition, could go towards tuberculosis, could go towards community engagement, could go towards knowledge or technology or any of the pieces within the collaborative, which could then be funded through the funding partner. Then we have a host of implementing partners, those partners who will actually deliver the interventions on the ground. And they're very important. We're trying to look at implementing organizations with a lens of people who have already worked in the tribal communities. Then we have the fourth one, which is what we call as knowledge or technical partners, partners who bring in vast experience of curating an understanding of the tribal people, maybe would have tested a very interesting intervention which may work in the tribal population, which can then be used for scaling up. And lastly, we have the monitoring and evaluation partners. Now, people who want to collaborate with us can collaborate on any of these levels. They could be a core partner, they could be a funding partner, they would want to be implementing partner, they may want to be knowledge technical partners, or even on the monitoring and evaluation. Funding, of course, is an important aspect, and therefore funding can go into different aspects of the collaborative itself, which could be, as I said, knowledge, technology, facilitating implementation, or any of those blocks that we have created.
Thank you, Shailendra. One last question I would like to ask Paresh is, the question has come for government leadership. How does government leadership get involved in the Tribal Health Collaborative, and will they bring in any intellectual contribution to the collaborative as well?
Of course. I think we just have about a minute to end. And yes. I think I would just leave with the thought that our engagements with the Ministry of Health and Family Welfare, with the Ministry of Tribal Affairs, with WCD has brought in a lot of encouraging and I think inspiration for us to kind of go ahead. They would be more than happy to bring in their long expertise and experience into what we are trying to do. But maybe I think that's a conversation we should delve into a little deeper at some other point of time, Ashwin.
Thank you, Paresh. And I request Isha to put up the slide just to refresh everyone on the ways of contributing on the collaborative.
Yeah, so as we've said through this talk, this is basically a multi-stakeholder collaborative that is committed to ending preventable deaths among Indian tribal people. You can reach us on the email ID that I've given. There's a phone number as well. And our request is that this is a call to action. We believe that by joining forces, by joining hands, we can actually create impact at scale, create impact for the tribal population of India. You could be a core partner, knowledge partner, funding partner, technical partner, or implementing partner. Thank you very much.
Thank you. Thank you, everyone. Thank you, Paresh. Thank you, Shailendra. Thank you, AVPN team.
Thank you so much from our side as well, Ashwin, Paresh, and Shailendra. And it's always, thank you for sharing your insights. And it's always good to end a session with a start for a call to action. So I'm very much looking forward to what's happening next. With that, we have come to the end of this session, Improving Primary Healthcare in India through Tribal Health Collaboratives. This session is made possible with kind support of our festival partners, Bill and Melinda Gates Foundation, Sesame Workshop India, the Rockefeller Foundation, COVID Action Collab, V&V Advisory Services LLP, the British Asian Trust, WPP India CSR Foundation, Catalyst Management Services PTE Ltd, and Satwa. We encourage you to continue chatting with your speakers and fellow delegates in this session, so please make full use of the messaging and meeting function of our festival platform. Do share your highlights of this session on social media, and remember to tag us using the hashtag AVPN South Asia 2021 and hashtag social impact. Up next, the session on investing in mental health care in India will be starting at 6:40 p.m. IST. Thank you, and please enjoy the rest of the festival.
Thank you.